So we have a few minutes for questions if some people would like to get us started. And I'm going to take the liberty of moving into our break a little bit late in order to try to accommodate people who are going to ask very well-defined questions. Sure.
I just want to say Strong Start is not looking at home birth. We are looking at birth centers, maternity care homes, and centering pregnancy. Medicaid does pay for home birth in some states, but it's not something that Strong Start is investigating.
Okay, thank you. We'll start over here.
My name is Ron Duplain. I'm with Private Practice Maternity EHR. Thank you for the IOM, the sponsorship, and for your participation. My discussion is directed at Dr. Barth. I can speak as an EHR vendor. I can join the discussion about the use of data, but I'm here speaking as a patient. And I would like to echo Jill Arnold's plea to have representation of the patient in this discussion. I think it's really important, particularly in the decision-making process. Speaking as an engineer, I found the discussion on risk to require some improvement. When I look at the risk discussion that's been in this room, it's been highly categorical. But as a patient, it's a continuous variable to me. When I'm supporting my partner in her maternity care, we have 2 children, I'm not evaluating whether she's low risk or high risk. I'm evaluating the likelihood that certain things will happen to us, whether we're a numerator in that clinical quality measure. And I'm evaluating the impact of that on our family and our preference. And that's important to us. And to move this specifically into what I'd like you to comment on is the use of data in the patient-provider relationship and the use of shared decision-making. Because your use of affective temperature is a very real thing in labor and delivery room or in the home. It helps to really understand and frame the provider and patient biases. But using data, though, I'm not a population, I'm a person. We are a family, and we have our own decisions that we are making, and our preferences will greatly impact our relationship with our risk. And the use of data is very important to share a decision, and I'd like you to comment on that. Thank you.
Well, I think that's the great question and very poignant, and it gets to the issue a little bit of what I mentioned of numeracy. That one-on-one conversation is very different. If I'm counseling a patient who's a software engineer and has a certain level of appreciation of numeracy, or that's what they understand and live with, I would probably have a bit of a different conversation with you than I would one of my patients who's 4 months in from Somalia from our health center who's scared to death. I would not be presenting granular numeric data and odds ratios with confidence intervals like I might with you. And part of it gets to, as providers, whether midwives, obstetricians, family practice docs, we have to determine what of our own value judgments are we going to bring to that conversation. That's risky. I don't know you. I don't know your background. I don't know if you've had a prior terrible experience with a VBAC, so I can't tell you a thing. I don't know you. So I have to make a decision immediately in someone that I don't know that well, how, and I hate the word, but how paternalistic or how directive I will be. What words I choose to describe risk will influence that decision. For example, I could say your risk of having a neonatal death is under 1%. And that sounds not, that to many that would be okay, that's not so high. But I could turn it around and I could say, your risk is 3-fold higher if you have a home birth than if you choose to deliver in the hospital. And I've suddenly dramatically changed the context of that conversation. So I have to read the patient, many of whom I haven't really had a relationship with before, try to understand what they bring to that conversation, try to check my own personal biases, and have that conversation in a way that somehow matches. What are they going to receive? What am I going to give? And try to convey information in a non-directive fashion. And I'll close with one more comment. The big issue today, especially with prenatal diagnosis, VBAC, things like that, is non-directive counseling. And I'm sorry, but as a human taking care of other humans, it is hard for me, if I do have an opinion about risk, not to be a human and advise that person on my opinion. I try to check it and not make sure it's too much, but and at the end of the day, we're humans trying to communicate with other humans. The best I can do.
Okay, Marion?
Hi, I just wanted to comment briefly on the WAC study. One thing that's always mystified me is why there's been this tremendous focus on the neonatal mortality risk when perinatal is really a better measure. And actually, the perinatal mortality risk, I think the denominator was like 331,000. And for the neonatal, if I remember your slide correctly, it was around 12,000. So it was, very underpowered analysis. And for the perinatal mortality, they found no increased risk. So the whole hoo-ha about neonatal mortality was sort of misguided in a way. The other comment I wanted to make is, I think you just alluded to in your last statement, the difference between absolute risk and relative risk. People get hysterical when the neonatal mortality risk is 3 times, for home birth versus hospital birth. But I think some studies might have found a little bit higher relative risk, some studies didn't, but all of them found the absolute risk to be very low. And that's, for rare events, that's also a very significant figure that can be used for clinical decision making, and something I think that's been very underutilized in this discussion. Absolute risk.
Any comments?
Yes, thanks, Marion. With regard to the wax paper, I suspect we could take a day or two to talk about what studies were included in which outcome variables, and I think the change in the denominator had to do with the inclusion of one study or not, depending on whether neonatal deaths were extended out to 28 days. I think the last question is probably more germane, and that is the conveyance of risk to any particular individual. We tried to be very careful in the committee opinion to say, and the words, if you read through the text, is that although the absolute risks are low, there may be an increase in the risk of neonatal death. But I will defer to a very respected colleague of mine, Mike Green. Mike Green is a perinatologist at Mass General. He's one of the editors on the New England Journal of Medicine responsible for maternal child health publications. And on a separate subject, so we can move it away from the emotion of the home birth issue, he closed one of his editorials with a very short sentence that said, ultimately risk, like beauty, is in the eye of the beholder. And I think in a very small number of words, that gets to what we're talking about. Different people will value different outcomes and risks differently. And I think we need to accept that. And our charge is to convey what we do know based on the imperfect information that's out there.
Okay, thank you.
Elizabeth Armstrong, Princeton University. I want to address the assertion that Dr. Barth made that no one can force a woman to have a hospital birth. Someone can and someone has. The someone is the state, often acting at the behest of obstetrician gynecologists. Women have been forced to give, women who preferred to deliver at home have been forced to give birth in the hospital. Laura Pemberton in Florida is one such case. There are other cases, and women have also been forced to have cesarean sections that they did not consent to. I think this is a very important point.
Granted, Dr. Armstrong, I fully admit, I guess I was quoting Jeff. What we should say is no one should be forced to have a hospital birth. Yeah.
Mm-hmm. Thank you.
Okay, my name is Ida Dara. I'm a certified professional midwife, and I have a quick comment and then a question. My first comment is acknowledging Dr. Barth's statements about the voluntary nature of data collection that we have right now, and NARM, as the certifying agency, acknowledges this, and we are taking steps with the Midwives Alliance of North America data collection system to combine our efforts in 2015 for a mandatory data collection of all CPMs in that year. So that is one way we hope to address that problem. Now, my question has to do with this interesting concept of listing on the birth certificates the intended place of birth, and I think that's a great movement forward. But if the intent of that is to really better understand the risks or the factors involved in out-of-hospital birth that need to move into the medical system, I think we have to also look at whether there's a care provider involved in it. We're seeing a lot of increase in unassisted out-of-hospital births, and that's partly because women want that and partly because they don't have any licensed providers in their area or in their state to help them with a home birth. So if you have a transfer from an out-of-hospital setting, it would be important to know whether this was unattended, whether it was attended by a friend, a neighbor, a doula, or whether there was a qualified provider involved in making the risk assessment that led to the transfer of care. So I urge that to be considered. And if you have any comment on how we might do that on these birth certificates.
I really should defer to Marion. I don't work with the birth certificates, and Marion probably can speak more to the feasibility of some of these changes we're all thinking would be wonderful.
Given what trouble we've had to revise the birth certificate that we have now, we don't have a global revision planned. There may be some minor tweaking that may occur about 5 years from now to improve data quality on specific items. I think the best approach is to write a letter to NCHS, probably to our division director, and I can give you addresses and so forth. But it's pretty hard to change the birth certificate. By the way, I think I mentioned yesterday that Oregon does have a question also for hospital births on whether it was planned to be a hospital birth or not, which is a super big improvement, but not by any means all that we need to get the good data.
I'm terribly sorry. We're going to have to limit the number of comments unless you don't want to have a break, and that's fine with me, but I think some people would like to have a few minutes. So we'll take at least one more and then maybe take a break after that.
I will try to be brief. My name is Kate Ryan. I'm with the National Women's Health Network. So we're a national membership advocacy organization. And we also do a lot on trying to promote women's voices and evidence-based healthcare. And those two things are not mutually exclusive or even contradictory. And I feel a lot of the discussion makes it sound as if those two things are contradictory. I'll try to keep my comments brief. I had a couple of reactions, some with my policy hat and some with my personal hat. Dr. Cross-Barnett, your presentation was wonderful, and I think it's great that CMS is, or rather CMMI is starting to advance data collection and really think about this. Two of my comments, one being with my policy hat, thinking of this culturally, talking about hospital birth as traditional. Up until very recent history, hospital birth is not a traditional way to give birth, and talking about home birth or out-of-hospital birth as non-traditional is less helpful as a part of the discussion.
Probably should have said standard.
No, and that's okay, and that's totally fine, but I think this is exactly the right context to talk about how we choose the words we use when we talk about out-of-hospital births versus hospital births, which versus is not a helpful word, for example. From a personal perspective, I was born at home. My mother is a doctor of psychology. She is the chief of a hospital. She had all of her children at home with, dare I say it, now this was the early 80s, a lay midwife, and is also someone who buried our umbilical cords in the backyard. So comments that say things like, oh, it's crazy granola people who bury placentas and umbilical cords in the backyard is also less helpful as a way of talking about who chooses home birth, why they choose home birth. And so I mean this in the most constructive way possible. Hearing that, all I could think was, well, my mom did that, and which is an emotional reaction.
So
right. So
I guess maybe I feel like as a member of the club, I can make fun of myself.
And that's fair, and actually probably does change how I would perceive your comment, which is also exactly the issue with risk. So I guess my questions about how we talk about risk and some of Dr. Barth's comments about the emotionality of birth, that's not really different than any hospital decision. All hospital decisions are emotional, and yet we're prone to talk about birth as if it's somehow more emotional. Working for a feminist health organization, my question to myself is, why do we talk about women's health decision making as somehow innately more emotional than other health decision making? And so when we talk about risk, I would say with contraception as an OBGYN, you would say the risk of a VTE is very small. However, the risk of a VTE from the patch is 1.5 to 2-fold higher than the risk of a third generation pill, which is a very different sentence then. Although the absolute risk of a home birth is of a neonatal death in a home birth is very small, it is 2 to 3 times higher. So the although at the beginning versus the however mid-sentence also changes the way risk is perceived. And those two comparisons for me really drove that home. So it's sort of obviously a comment, but just a couple of different things I think we need to keep in mind as we talk about these issues.
Thank you. And so thank you very much to the panel. There will be another opportunity to bring up some comments after the next panel, and I appreciate your attentiveness. It's now 10:39. So I'm going to turn this over to Maxine to decide whether or not we're going to have a break.
We will. We will take a break, and it will be an abbreviated break because we'll probably have to cut a little bit into our lunch, which will be the way we will manage this. So let's take a 10-minute break and try to get back so we can start about 10 minutes. Thank you.